let's see. I see a lot of people signing in, so I think we can go ahead and get started. Welcome to Ask the Doc Part 2, a Lupus Town Hall program. My name is Adrienne Fernandez.
I can't hear.
And I am, let's see. Sounds like we're having some audio issues. Dr. Ballou, can you hear? I apologize. We'll start in a moment. You were able to hear a minute ago, so I don't know if something happened. Can you hear us, Dr. Ballou?
Can anyone hear me?
Mm-hmm.
We can hear you.
I can't hear anyone
hear
else.
us. Alex, are you able to jump back on and help Dr. Ballou for a moment?
Yeah, let's see.
For some reason, when you were on, he could hear you. I apologize, audience. We'll get started in a moment.
I can see Adrian trying to say something, but I can't hear her.
Well,
Dr. Chacon says she cannot. So, Dr. Chacon, can you hear? She can't hear. There's something with Dr. Chacon and Dr. Ballou that's going on with their audio. They were fine a minute ago.
well, let's ask the audience. Can the audience hear us? Let's start there.
Hello, let's see. Rita, are you able to tell us? Can you hear us? We have a lot of people signing in. It's an audio problem.
Dr. Ballou can log out and log in again.
Log out and log in.
Mm-hmm.
Oh, we can hear.
I can hear Alex.
Okay.
Okay.
So you can hear Alex, but not us? Oh, that's odd.
Maria, can you hear me?
I can hear you, Dr. Ballou.
And I can hear Maria. It's only Adrian that I can't seem to hear.
You can hear me, Dr. Ballou?
Yes,
Okay.
Dr. Siraj, yes, I can.
Let's see. Can the audience hear me? Let's see if we can get any. I apologize, everyone. Hopefully you can hear me. Yes, they're saying yes. Okay.
Yeah.
I mean, I don't.
Dr. Blue, can you still hear me?
Yes, I can.
Okay.
He just
Why don't
can't.
you just-
He can't hear me.
Yeah, and you're still not hearing Adrian?
I'm not hearing Adrian, but I heard Maria, and I heard Dr. Siraj.
Why don't, if you want to just try to log out and then log back in real quick?
Me or Dr. B?
No, Dr. Blue. Yeah,
Okay.
Dr. Blue.
And what Dr.
And then I'll
Chacon's
just-
having problems as well, I think.
Okay.
Okay, then yeah, she can try the same thing.
Okay. Can somebody communicate with her and see if she can hear you?
I will let Dr. Chacon know.
Okay. And then, yeah.
Okay. And then as soon as they sign back in, we will get started, everyone. Sorry about that.
Sounds good.
Technical difficulties. Everything was fine before we started and something
Always.
happened. So
Always.
we know how it works with virtual programs.
Okay.
Okay.
Well, hopefully everybody is enjoying this nice fall morning, wherever you reside.
The Ohioans are. Anybody outside of Ohio, not really sure, but
Yeah.
it's sunny and pretty, so we'll take it, and it's going to get a little warmer.
Yeah, although there is a storm brewing for tomorrow morning.
Yeah, for tomorrow, for sure. So we'll see how that
soak it up
goes.
today.
It'll be rainy by Halloween.
Yeah.
Always rainy.
Wow. Yep.
I was waiting. We've only had like one real like normal
Yeah,
gray
fall day.
rainy day.
Yeah.
They keep saying you're echoing, Alex. So
Oh, I might not have.
I'm gonna say Okay, let's see. Just letting everybody know. Okay, let's see. Dr. Chacon, can you hear us?
I can hear you now.
Okay,
Thank
now
you.
we just need Dr. Ballou, and then we'll be ready to go.
Thank you.
Okay.
Yeah, we had like a nice half-hour-long chat before with everybody. And then as soon as I hit live, it was like,
Let's see, can we ask anybody a question in the comment section? Let's see, what can we ask them? Don't know. Don't know. Does anybody have a rare talent? Does anybody have a rare talent in our audience that we should know about? Share something unique about yourself.
There we go.
Let's see. Nobody's being brave this morning. We're not there yet.
Adrian, what's your rare talent?
Alex is going to say something like being annoying. I don't know.
You took the words right out of my mouth.
I don't know if I have a rare talent. I'm a vegan. Does that count? That's not really a talent, but
It's a lot of skill and a lot of energy.
a lot of energy. I was a vegetarian for probably 30 years. Then I went vegan. So, you know,
Wow.
haven't had bacon since I was 18.
That's
Everybody
my
thinks
favorite.
that's amazing.
When everybody's like, "What's wrong with her?" I'm like, "She hasn't had bacon."
She hasn't had bacon in many years. That's her problem.
Good for your cardiovascular health.
Right? That's what I
Not sure
figured.
about your bones, though. We
I
should
know,
talk about
right?
your
I know.
Calcium intake.
I promise you, my rheumatologist is always on top of me about that. She kind of looks at me like, you need to be eating yogurt and drinking milk. But, let's see. Oh, it says Dr. B treated my mother in the late 70s and 80s. Okay.
Ooh.
Patient that's saying that. My cousin is a retired astronaut. Ruth is sharing that. That's pretty cool.
Love that. That's super cool.
Oh, Jody Olson. Hey there, girl. She says animal advocate, groom dogs, and does artwork. Love it.
There you go.
Oh, nice.
Love
Been in that world
it.
for 11 years.
Yeah. I don't know where our Dr. Ballou is. We'll have to just see.
Well, do we?
Dr. Antonelli, are you able to double check on
I was gonna
him?
say I can shoot him text message, but
Okay.
should we think of
And
a
then-
backup plan?
Yeah, if you.
You're
I
it,
don't know,
Dr.
Adrian.
Ant.
Yeah.
Well, no. The idea would be, would you like to moderate questions?
Moderate
And then
questions.
we can, because
Okay.
we
That's
know
fine.
how to bounce the questions around.
Yeah.
Yeah, that's
If
fine.
you
I
can
can
just-
add him in, so I'll jump back off, and then I can add him in when he gets back. So if you want
Okay,
to
so
start.
if when he arrives again, we will he'll take over. I'll let him know where we're at in the process.
Okay.
Okay,
All right.
so back to where we were. Greetings, my name is Adrian Fernandez. I work for the Lupus Foundation of America, Greater Ohio chapter. I'm the lead project coordinator here. Thank you for joining us this morning. We apologize about all of the technical difficulties we're having. A few notes of housekeeping. All lines have been muted to ensure audio quality. We have received many pre-submitted questions. If you would like to submit an additional question during the program, please use the private chat function to do so. I do want to say a huge thank you to our sponsors, GSK and the Ohio Commission on Minority Health, who make programs like this possible. We would not be able to do what we do without your support. So again, thank you. I see Dr. Ballou joining us, so that's great. We have a little bit of an echo, Dr. Ballou, so I don't know if you're able to help with that. And thank you to Metro Health Medical Center for moderating and providing our wonderful medical experts. Thank you to all of our medical professionals who volunteered their time and energy to make today possible. We know how busy you are and the strenuous demands that your job places upon you. So thank you. Two final notes. Please stay until the end. Dr. Nora Singer, who is director of the Division of Rheumatology at Metro Health Medical Center, will be joining us for a few moments at the conclusion of the program to discuss current lupus research and clinical trial opportunities. In addition, if you stay for the entire program and fill out the evaluation at the end, you will be entered into a drawing to win one of two $50 gift cards to Target. So everybody can use a Target gift card, especially at the holidays. So let's go ahead and get started with the program. We have a wonderful, excellent panel today, and let me introduce briefly each one of them. Dr. Maria Antonelli is a board-certified staff rheumatologist in the Division of Rheumatology at Metro Health Medical Center, and she's also an assistant professor of medicine at Case Western Reserve University School of Medicine. Dr. Antonelli, do you want to give a little wave? Dr. Stanley Ballou is a board-certified rheumatologist who recently retired from Metro Health Medical Center, where he was the director of the Division of Rheumatology from 1998 through 2009 and director of Rheumatology Fellowship Training Program from 2004 through 2016. He currently serves as the medical chair of the Lupus Foundation of America, Greater Ohio Chapter Board of Directors. Dr. Daniela Perella is a board-certified endocrinologist at Metro Health Medical Center. She is also trained in geriatric medicine, serves as an assistant professor at the Case Western Reserve University School of Medicine. Dr. Aisha Siraj is a board-certified interventional cardiologist at Metro Health Medical Center and an assistant professor at Case Western Reserve University School of Medicine. She is also a fellow of the American College of Cardiology. And finally, Dr. Gina Chacon is a board-certified internist and rheumatology fellow at Metro Health Medical Center in Cleveland. She has previous experience and expertise in cystic fibrosis and wound care and is transitioning to treating many rheumatologic conditions. So welcome to all. Thank you so much. And I am going to go ahead and turn the floor over to Dr. Ballou. Thank you.
Thank you very much, Adrienne. Can you all hear me?
Yes.
Excellent. Thank you for that kind introduction. I'd like to welcome all of our participants. I'd like to thank the Ohio Lupus Foundation and Adrienne specifically for putting this excellent program together. We did have a similar program last year, which was highly regarded and very popular, and we've decided to do it again this year, and we had an overwhelming response to our ask about questions, and we have quite a few excellent questions related to lupus, as well as many aspects of lupus, such as heart disease, thyroid disease, and this is one of the reasons, of course, why we have our excellent panel assembled here today. We're going to begin with questions that have been submitted, and we'll have an opportunity later in the program to answer questions that are submitted from the audience as well. If you have any questions, don't hesitate to make a comment, and we'll try and address your questions as best as possible. The first question is not an uncommon scenario. It's by an individual who says, I've had a lupus diagnosis for many years and recently had to switch rheumatologists. My current pulmonary lung doctor treats me for interstitial lung disease and suggested that I might also have scleroderma or mixed connective tissue disease. My current rheumatologist is not certain which of these disorders is contributing to my lung disease and lupus. So I'm wondering how I can advocate for myself. And this is a complex question, and we'll let Dr. Antonelli address this issue.
Thanks, Dr. Ballou. So complex question, complex situation. I think it all comes down to semantics. This is a person who is asking what's the cause of my autoimmune disease, right? What are we going to call it? And I think it's difficult from the patient's point of view because you want a name and you want the answer. I think what we should try to remember is that we can call it whatever we want, but really it comes down to most likely the pulmonologist is saying you have a particular type of interstitial lung disease that I think is coming from X. It's coming from, what did we say? Now scleroderma. But I've been treated for lupus. And so now do I have two things? And I would say it's common as autoimmune diseases progress over the years that rheumatologists might question the initial diagnosis. And that's, it puts a patient in a tough position, but sometimes it could even come down to whether the pulmonologist or the rheumatologist wants to use a specific name because certain drugs are used for certain types of interstitial lung disease. For example, something that was newly approved for use of scleroderma-related interstitial lung disease. And so if the original treatment wasn't working, maybe the next treatment will be. Can't hear me, Dr. Ballou. Alex, we're back where we started. Adrian or Alex, I have in the private chat that we can see, it says Dr. Ballou can't hear me.
You hear me? Okay. Again, here we go. So I think maybe what we should do is have maybe Dr. Ballou work on his audio in the background. And then if you want, I can take over moderating questions. And
I think that's okay.
Okay. So we'll continue right now with Dr. Antonelli with the answer to that question, and we'll go from there.
Yeah, no, I had just finished, Adrian. So if you want to go on to the next question.
All right. Sorry, I was trying to figure out what was going
on. That's okay. Yeah.
So, okay. We have a question right now. It's kind of a crossover question. So how common is it to have POTS and lupus, Sjogren's, and Raynaud's? So I am going to say that is both cardiology and rheumatology. So who wants to take that one?
Dr. Siraj, do you want to comment on the prevalence of POTS in certain types
of
autoimmune
Dr.
disease?
Siraj, since POTS comes up frequently?
Sure. POTS by itself is a difficult, it's easy to diagnose, I would say. Take some steps, but it's one of those entities which is difficult to treat, especially if you have lupus, Sjogren's, scleroderma, or any autoimmune disease. The prevalence is around 10 to 20% in these patients that I've seen. If you have some level of autoimmune disease. Yes, we see a lot of POTS patients coming with or without the diagnosis, or they're in the process of being diagnosed with lupus or any other autoimmune disease. So yes, we do see quite a bit, mostly young patients, rather than older subset of patients, and they might have that as a first manifestation of any rheumatological disease too. That is also something that I've seen in young girls, coming into the office with POTS diagnosis only, and in the background, then when we start inquiring about other symptoms and signs and send some workup, it has come out to be positive. So it might be the first manifestation, or it might be a consequence or a sequelae of an autoimmune process that's going on. So yeah, that's not uncommon or not unheard of.
Great. Dr. Ballou, would you like me to keep going?
Yes, please.
Okay. Dr. Siraj, this one is also for you. As a lupus patient, should I be taking a baby aspirin daily to prevent heart disease?
So that's a good question. There's no right answer and there's no wrong answer. We know that it's an autoimmune and it has pro-inflammation. It is not wrong to take aspirin daily, but I would definitely suggest that you should be getting screened for your coronary artery disease, have your risk score stratified before we start something like aspirin. So I would definitely ask you or somebody who's, want to try over-the-counter baby aspirin to just have a primary care visit so that we can do a scaling, which is called ASCVD score, and that helps us. So there could be other risk factors that is contributing, how, what's the age group, what are other risk factors, and et cetera, not just aspirin and you have a diagnosis of lupus.
I think it would also be important for this patient and all our lupus patients to think about if they have ever been screened for antiphospholipid syndrome. Even if they've never had a clot, I believe the most recent recommendations are if they have some of the antibodies, even if they've never had a clot, that baby aspirin is part of that recommendation panel. But that would be on an individual discussion with your physician. Yeah.
Okay, great. And this one is for Dr. Perella. It is, I have hypothyroidism and lupus. I am taking levothyroxine, Plaquenil, and Benlysta. Does Benlysta and Plaquenil help treat hypothyroidism? Both diseases make autoantibodies, and Benlysta and Plaquenil reduce autoantibodies.
So yes, that again another great question. So again, both hypothyroidism due to Hashimoto's disease and again lupus, they're autoimmune disease. Okay, so these medications, they don't directly affect the absorption of the levothyroxine. So technically, they will not change how much medication you need. Now, a couple of things. So hypothyroidism, of the amount of levothyroxine that you need, to a certain extent depends of how long you have hypothyroidism. The longer that you have an autoimmune disease, the most these antibodies will attack the thyroid and will decrease your own thyroid function. Therefore, if you have had again hypothyroidism for a very long time, it's very possible that your thyroid is not producing anymore thyroid hormone. Therefore, you are getting everything for the levothyroxine. So again, these medications that affect the immune system will not affect at all your hypothyroidism. But let's say that you are at the beginning of your hypothyroidism disease and you still have a lot of your thyroid that is still working. These medications that decrease the autoimmune disease can slow down the process of the antibodies attacking the thyroid, and they will decrease or they will slow down how rapidly you need to increase your levothyroxine dose over time. So it depends a little bit of where you are in the disease, but let's say again that you have had this condition for a very long time and you are using a dose that we call body weight dose already, then very unlikely that these medications will affect the amount of medication that you need. A lot of things can change your levothyroxine needs. So definitely it's a good idea to keep checking your thyroid hormone every 6 months to a year, and then just keep an eye on it with your doctor.
Great. Thank you.
I think I'm back with audio. So can I go ahead and introduce the next question, Adrian?
Take the floor, Dr. Ballou.
Okay, because this is an important question. I have lupus and Sjogren's with multiple symptoms, including dry eyes, dry mouth, and other symptoms. I've chosen not to use Plaquenil since the ibuprofen is effective in managing pain. Will you provide tips for managing both lupus and Sjogren's? And let's let Dr. Gina Chacon answer this question.
Thank you, Dr. Palou. This is a very important question to try to help in the management of both conditions. For example, discuss with your doctor about tips that might help. Start with anti-inflammatory diet, no? Avoiding processed food, decrease high amount of sugar, also avoiding high amounts of alcohol, stay healthy. Also, diet that is high in omega-3 fatty acid, like fish, maybe 2-3 times a week. Also, good amount of sleep every day, like at least 7 hours, might help to decrease the inflammation and feel better and decrease the fatigue. Also, exercise daily, like at 20 or 30 minutes a day. For the dryness of the mouth, no, yes, I see that it's taking medication, but also being hydrated, drinking small amount of fluids frequently during the day, especially during summertime. For the dry eyes, no, also being in a place where there is a humidifier, using glasses, sunglasses might help. Also, trying to talk about medications that decrease the inflammation. I know patient doesn't want to take medications that maybe like over-the-counter anti-inflammatory agents like NSAIDs, like ibuprofen, naproxen. Talking to the doctor is important. Also, there are some good websites that I think everybody should be just using, like the Lupus Foundation and the Sjögren's Foundation, that can give more recommendations. I think maybe Dr. Antonelli has more recommendations.
Yeah, I would urge the patient.
Do you have anything to add to that, Maria?
I do. I would urge the patient to reconsider taking hydroxychloroquine or Plaquenil. If this is lupus, we know there's less morbidity and less mortality in patients who are taking the hydroxychloroquine. And I think the question did say the patient was taking ibuprofen over the counter, things like this. Even though we think about ibuprofen as safe, it's over the counter, it still has a lot of toxicity. And depending on the patient's age, there's high risks of bleeding, high risks of kidney problems for patients who are taking certain doses chronically. So I would say, even though ibuprofen can be helpful, I think reconsidering using hydroxychloroquine to help with both morbidity and mortality for this lupus patient.
Thank you. I didn't hear Dr. Antonelli.
I'm good.
Comments were very good. The next question is very challenging, and perhaps Dr. Antonelli can address this. Is lupus itself fatal, or are there medical-related problems from lupus that can be fatal?
So I love this question, complex, but I think there's no other time in history when lupus fatality or the death rate from lupus has been so low. If we think back 100 years ago, 500 years ago, patients from lupus, there was going to be a death rate of X. From kidney disease, from inflammation in the heart, inflammation in the brain, things like that. And there was no treatment. We didn't know about it. We didn't understand it. And now in the last 100 years, treatments have been developed. And so now the fatality from lupus itself has gone down. And yes, there are still patients that die from lupus, but more it's the complications of lupus, like lupus heart disease, the typical cardiovascular disease. We know Dr. Siraj could comment on this, that lupus patients should be thought of as almost a person with diabetes, that they should be screened earlier and treated aggressively. But now it's much more common, I think, that patients with lupus die from the complications of the medications, from immunosuppression and infections and things like that. So, but I would say overall, optimistically, fatality rates are much lower than they have been.
Thank you. Let's move on with another question for our cardiologist. And this is also an important question for all of us, really. What specific heart health screenings or tests do you recommend specifically for lupus patients? Or Dr. Siraj?
So as you know, Dr. Antonelli was absolutely on the right track. These days, patients don't particularly die of lupus or a lupus flare, but they do die of the complications, and one of the complications are cardiac disease. And we would like to treat those patients irrespective of their other risk factors as if someone needs screening at an earlier age. So if you're diagnosed at an age of, teenager or early 20s, we start screening them earlier on rather than later on. So when a patient arrives with the diagnosis of lupus and has no other, we start with the basic EKG. So EKG is something that tells us a lot of information in the office settings and a clinical history to start with. So symptoms of heart disease, exertional shortness of breath, symptoms of angina, they might, an early age, they might not manifest themselves, or they might think about, oh, this is lung disease, but this is not heart disease. As far as other treatments are concerned for lupus, I have seen patients who've been on treatment for lupus, and they can have certain arrhythmias, which can be life-threatening in them and can go unnoticed for a long period of time if they've been on treatment, such as QT prolonging drugs, and et cetera, et cetera. So the first step in the office is to get a thorough physical examination, history, and an EKG. That's where we start from. And then, of course, if we go further, we all know that lupus can start from simple atherosclerosis of the coronary artery, give us coronary artery disease, but it can cause myocarditis. It can involve the valves. It can cause pericarditis. And that can also be a detrimental situation that they can end up having congestive heart failure. So we start from the basics, and then, maybe an ultrasound of the heart based on the symptoms. We do have something we call coronary artery calcium scoring, which we prefer to do in lupus patient early on to calculate their calcium score in the coronary artery. So there is a wide variety of testing based on the symptoms and EKG, but we would like to screen them as any other cardiac patient because they tend to have morbidity and mortality as a consequence of lupus.
Dr. Siraj, is there a young aged lupus patient that you would prefer not to see in your clinic for preventative health? Would you prefer to see patients in their 20s, or is it you wouldn't want to see them until their 40s? What would you say?
I think I would see them as early as possible just to have an awareness because when you're early on, you don't think about cardiac disease. So that's a bias already set in place because of the age group, but they're certainly at high risk. So we would like to see them earlier than later, maybe a yearly screening if they're doing fine, or a 3-yearly screening we can offer them. But yeah, if you're just diagnosed with lupus, we would like to have a conversation to open up that discussion that in future, you might have a cardiac complication that we need to prevent rather than treat.
Dr. Ballou?
Yes,
Okay.
I have selective hearing. I can hear you, but not Dr. Antonelli, and I can't hear Dr. Siraj either, but I can hear everybody else.
Okay.
So,
Great. That's
so I
great.
better figure this out. In the meantime, would you like to continue moderating the questions for our esteemed colleagues?
Absolutely. Thank you so much, Dr. Ballou.
bet.
Okay, moving forward. This is an endocrine question, so we will go ahead and ask Dr. Perella. How can my doctor tell if my fatigue, joint pain, and brain fog are more likely due to a lupus flare or my thyroid levels?
Yeah, so the most sensitive test is a TSH, thyroid stimulating hormone. We want to make sure that it's within the range. Patients who are very, very sensitive, I try to keep them between a range 0.5 to 2.5 to make sure that there's absolutely no question about them receiving a good dose replacement. But overall, that's what your doctor can do, or at TSH. There is this question, I get it all the time from my patients about getting a full panel of the thyroid hormone, the free T4, the T3. However, keep in mind that when we check for those hormones, free T4, T3, free T3, those tests are looking at your thyroid hormone level at that time, at that second, that minute. But they are not reading what are your levels doing during the rest of the day, the rest of the week. When we get the TSH, that is a most sensitive test that provides information about what are your levels during the entire weeks, and actually month, okay? When there's moments of your day during your week, it might not be again every day or every week, but if you don't have either enough thyroid hormone or if you have too much thyroid hormone at certain point of your week, that will create an exponential effect over your TSH. So again, the most sensitive lab that we can get is the TSH, and then we need to make adjustment of how much medication you need, or if you need medication at all, looking at your TSH. Again, a lot of little things can affect your TSH. One of the biggest things that I will bring up is make sure that you are not taking supplements, particularly supplements with like biotin. We can have some patients will take it for the nails and growth, which can be a significant concern for patients with lupus. Make sure that you are not taking biotin before you are going to get your thyroid function labs. At least 3 days minimum. We recommend about 5 days or a week because they can cause false abnormal test results. So then just make sure that when your doctor orders a TSH, that you're not taking any multivitamin or supplement that has biotin for at least 1 week.
That's a great suggestion. We do definitely hear about a lot of patients taking that, especially for their hair growth and, of course, their nails, as you mentioned. So thank you for that answer. I have a question for Dr. Siraj again. I have lipoprotein little a. My doctor says that because I have lupus and lipoprotein little a, I am at a 3-fold risk of having a coronary event. Is this true? And what does having lipoprotein little a have to do with my lupus?
Okay, so yes, you're at a high risk of having coronary artery disease. Lupus by itself is an autoimmune pro-inflammatory state, and we know that any time there is atherosclerosis, that it has to be a pro-inflammatory state. So these patients at a more risk of having coronary events if they have elevated lipoprotein A levels. And that's why we check lipoprotein A levels, certainly in some subset of autoimmune disease, because we screen them earlier based on their levels. So we can tell that the inflammation is ongoing and atherosclerosis will be ongoing, not only in the coronary arteries, but the carotids, but the peripheral arteries. So they're more prone of having vascular events if their lipoprotein levels are high.
Okay, makes sense. Let's see. Okay, another endocrine question. How might lupus-related inflammation or flares impact my blood sugar?
That's an excellent question. Yes. So when we are under stress, when our body is under stress, that affects our cortisol. Cortisol affects blood sugar. Depending again on the severity or the sensitivity of the patient. Sorry, having some. But yes, particularly in patients with type 1 diabetes, they tend to be more sensitive to inflammatory changes in your body, disarrangements like lupus flare that can cause significant hyperglycemia. The other important thing here is that patients with flares typically are treated with steroids, high dose steroids, and then steroids can again bring your blood sugar up. Actually, they can even cause what we call diabetes ketoacidosis. Diabetes ketoacidosis is a condition where the sugar becomes toxic to your body, and the body start producing acid, and then that can be dangerous, even fatal. So make sure that if you have diabetes, just remind your doctor, your rheumatologist, or your primary care physician before you are on a steroid, okay? If your hemoglobin A1C, which is the lab that tells us how bad your diabetes is, if you have a high hemoglobin A1C, even reach out to your endocrinologist and your primary care physician just to ask them if you need to make adjustments to your medications, particularly insulin. This is a scenario where it's a team player scenario where we all need to be in contact for the patient to have a better outcome.
Dr. Perella, if I could ask, you mentioned that particularly type 1 diabetic patients, you'll see the flare of blood sugar with inflammation. Do you see that with type 2 later in disease when they're more insulin dependent, or just it's that particular type 1 diabetes?
So no. So it happens to everybody, both type 1 and type 2. Again, there are some patients who are just more sensitive to other hormonal disarrangements, okay, than others. Type 1s, again, because they don't have their own insulin, then it's harder for them to compensate to other, again, hormonal disarrangement. Blood sugar does not only depend on insulin. Again, other hormones affect, particularly stress. And again, cortisol is the hormone that helps our body deal with stress. When we are going through stress and illness, again, like flare, then cortisol goes up, and then our blood sugar goes up. So then again, the more advanced your diabetes is, the more out of control your diabetes is, then it's harder for your body to deal with that increase of cortisol and increase of blood sugar. So yeah, it depends a little bit on the patient, but everybody can go through that, yes.
Thank you.
Great. Okay, moving along. Let's see, this is a rheumatology question. So when family, friends say they have heard of lupus, but ask me what lupus is, I'm not sure how to explain. We hear this a lot. Can you tell me in easy terms how to explain a lupus diagnosis and how it affects the body? Dr. Chacon, do you want to take that one?
Thank you. Very common, important question. I will say that it's a chronic inflammatory condition that sometimes comes and goes. We call it flares. And sometimes the patient will feel better or be fine, feeling fine for long period of time, and we call remission. And this condition may affect the joints, and patients may have pain, swelling, stiffness of the joints. It can affect also skin. Patient may develop rashes. Patient may be more photosensitive, and this is why they will avoid the sunlight or use more protection from the sunlight. They also may affect the brain, and patients may have more headaches, feeling tired, confusion, and even in rare cases, patients may have some seizures, psychosis. Also, this condition may affect the lungs. Patients may develop some shortness of breath or chest pain. Sometimes affect the heart. Maybe have inflammation of the heart or fluid in the heart. It might affect the kidneys. No, that is so very important to protect the kidneys, like Dr. Antonelli said, avoiding any over-the-counter pain medication. This condition may progress a chronic kidney disease. No, is trying to explain there are several organs that could be affected. No, and how important is to have the support of family and friends, and talk about very open about what a patient might need in certain times, no, like taking some time off from work or resting is very important. I would say just simple ways to find some support from family.
It's really,
Anything else for Antonelli?
really hits you at all angles, right? It just depends on the patient too. That's the hard part.
I think Dr. Chacon, a way that I found that's kind of a nice way to put it to patients, and I kind of use this metaphor with a lot of my autoimmune patients, is that the immune system, which is meant to fight off infections, is confused, and the immune system is attacking the body. It's nothing the patient did to deserve it. This is just the way it is, and it depends on which autoimmune disease you have. And in the case of lupus, it affects the skin, the kidneys, the lungs, whatever. Lupus is that heterogeneous disease, but really it's the autoimmune system or the immune system malfunctioning and fighting itself.
You know, continuing on with that, Dr. Antonelli, one of the questions I know that was pre-submitted and is coming up, so we'll just go ahead and go with it now, is how do you get lupus?
Mm-hmm. So I would say, again, similar to what I just said, where I kind of applied this to all of my autoimmune patients, whether it's rheumatoid, lupus, Sjogren's, that we are the product of evolution from thousands of years, that our ancestors who had kind of poorer sensitive immune systems, they died off from viruses or bacterial infections and things like that. And we and our grandmothers and great grandmothers and all this kind of stuff, they had immune systems that were maybe a little more sensitive, and they were able to fight off those infections. And so the cost of that is the immune system is a little more auto-inflammatory, a little bit more able to fight itself. And so we use what we call the two-hit hypothesis. You have the genetic predisposition. We know in lupus there's many different tiny little genetic markers that put families at risk for autoimmunity. And then there's something in the environment that triggers it. In lupus, as Dr. Chacon mentioned, the sun is a big factor, but whether it was an infection that happened to a person in their childhood, in their youth, and then the autoimmunity slowly brews. But like I said, it's really nothing that a person does to trigger it. It's having that genetic predisposition with something in the environment that sets that second hit off.
Okay, great. Thank you.
I think that's a very nice way that Dr. Antonelli has put on, because even in heart diseases, I've had some patients with a similar family, siblings being infected, and one of them might have a valvular problem, another might not have anything at this stage in their life. I've come across that conversation, and I'm glad that she explained it really well in terms of when we are talking about immune system going bizarre and attacking the valves in one sibling versus other in terms of genetic predisposition and some exposure to the environment. Another might not have it or might have a later consequence of some pericardial disease, but there are two different aspects I've seen in one family, or things like that. So it's very important to explain that it can manifest itself in different ways too. It's just in attacking the whole body. And even one organ, it can have different manifestations. It might not just be coronary artery disease. It can be a valvular problem. It can be a pericardial disease, and it can be in the same family, two subsets of siblings, or maybe grandmother was having coronary artery disease, but now I see a granddaughter with pericardial effusion. So those are the few things that we have to let them know, that this is how it really manifests itself, because it's an immune response to the whole body that has gone bizarre.
Thank you, Dr. Siraj, for that additional information. Let's see. Dr. Balud, I don't think I'm going to let you off the hook, okay?
Okay.
Does lupus make you tired and depressed?
Well, thanks for that question. And the answer is it can. Lupus, as you have heard, is a very complicated illness. It's difficult for patients to understand. It's even difficult for doctors to understand.
Mhm.
Because of its complexities and the multiple types of symptoms that can affect your heart, your thyroid, your joints, it can lead to mild depression and anxiety. We're aware of this. Patients should be aware of this. Their families should be aware of this. We need to do our best to try and control the symptoms so we are less susceptible to depression and anxiety. But most importantly, patients should not worry that this is going to overwhelm them. They should be aware that treating the lupus successfully can lead to improvement in their depression. And this is what we strive for.
Great. I think that's a really good point. And just to add to that, having a support system in whatever way around you, whether it be family, friends, colleagues, or all of the above. And of course, call us. That's what we're here for. We're here to support you. So I think, just having that support system is incredibly important. So thank you, Dr. Baloo. Going to back up and ask one more question regarding, this is interesting. We'll throw this one to Dr. Antonelli. I have a hard nodule, a P, at the base of my forearm near my elbow. I read that 10% of lupus patients have this. What is this? The nodule swells, gets infected, and is tight.
Thank you, Adrian, for that very interesting and challenging question. So when I was thinking about this question and discussing it with one of my mentors, we were thinking perhaps the patient is an overlap patient. Perhaps this is a person who has something called lupus, which is rheumatoid arthritis with lupus. And maybe it's a rheumatoid nodule at the base of the elbow, which is a very common place to get them. However, if that's not the case, maybe it could be something like a lupus erythema nodosum, which is a type of paniculitis. Another of my colleagues thought maybe this could be a tumid lupus, which I'm not exactly sure if that's a classic place for it, but the idea is inflammation in the subcutaneous tissue, so in the tissue under the superficial skin, becoming inflamed. And as skin stretches, can that become infected and things like that?
If it is a rheumatoid nodule, is there treatment for rheumatoid nodules?
Yeah, so rheumatoid nodules, they're fascinating. I have seen patients who have a rheumatoid nodule one visit, and they classically talk about them being very sensitive, that they, when they bump up against things, that they really are so painful. And then 3 months later, they're gone. They're just completely gone. And then I have other rheumatoid patients where they've had the same nodule. I can go back through my notes, and for years they are just there in that same place. And so really it depends on how bothersome they are to the patient. I've had some go to plastic surgery and have them excised, and that can be very definitive to say that that's a rheumatoid nodule. But really, you don't have to do anything about them if they don't bother you.
Gotcha. Great. Thank you. I just want to throw out a quick reminder too. Don't forget, you can always throw something in the private chat if you'd like to ask a question to the panel. But moving along, Dr. Perella, how might the hormonal changes of perimenopause and menopause affect my specific lupus symptoms or disease activity?
Good. Yes, that's a good question. So particularly estrogen can stimulate the immune system. And that's why pregnant women can have flares during pregnancy, and they need to be monitored for that, because when we're pregnant, we have like very high levels of estrogen. Then when we become menopausal, that means when we stop producing estrogen, then the estrogen level goes down, and then there is a little bit less stimulation over the immune system. So it's possible that the flares can become less frequent or less severe. This doesn't happen to everybody. There is a group of women who still have some symptoms like worsening arthralgia. And I will say that an important thing is that, again, it's very variable among women. Some women can be very symptomatic, they have a lot of menopausal symptoms, and some of these symptoms can be confused as flares or as again, just lupus symptoms, but it's not. It's just the menopause symptoms. So I will recommend to also, if you're having severe symptoms, just to talk to either your rheumatologist or your primary care physician doctor, just to try to differentiate if the issue is it a flare or what you're going through is menopause, and then we need to address that. Yeah, I think that will be my answer.
I think if I could comment, kind of going back to the question about how do I know if it's a thyroid flare or an issue or lupus, that's something that the rheumatologist could inquire by checking things like complement levels. So checking the C3 level, C4 level, which can sometimes be low in a lupus flare. And then again, if we're thinking about, is it a perimenopausal or menopausal type symptoms, that could also be correlated. And then also inflammation levels. So ESR and CRP are the classic ones that can be elevated in lupus. And then there's also parts of the CBC, that complete blood count, that can suggest inflammation depending on what's going on. Sometimes we see the white count can be elevated. Contrastingly, in lupus, we can see them go lower if there's a lot of disease activity. And if you look at the differential, which is looking at that spread of the white blood cells and seeing, are there far lower lymphocytes or more neutrophils, things like that, that can also suggest, or platelets, being low platelets, that could also be suggestive of lupus activity. So.
Thank you. I just would like to say too, I'm hearing that the private chat is not viewable to the audience, but the comments are. So feel free to ask in the comments. And we have a question that came in. I have lupus with severe food allergies, hives, and anaphylaxis events that require going to the ER or calling an ambulance. How common is this with lupus? So I guess we'll start with Dr. Antonelli again.
Oh my, oh no. Well, so, okay. I'm thinking these are the on the spot questions. These are hard. So I'm thinking the allergy part of the immune system, which is generally separate from the lupus type 1 Th1 versus the Th2 types of the immune system. And obviously they're all communicating and talking. I don't think it's that unusual. It's not very common though. I can think of a handful of patients that I have that have what's called angioedema, where certain triggers can trigger lip swelling, tongue swelling, and even breathing problems. And we know for a fact that patients with immunodeficiencies, which is lowered immune systems, are at risk for autoimmune diseases. So in these cases, this is where the rheumatologist works with an immunologist and allergist, like the famous Dr. Fernandez that we know around here. So where we're working together to help the patient.
Great. Thank you, Dr. Antonelli. We're also getting a question about ketamine therapy. So how does it work and who would be a good candidate for it? So I don't know which of the rheumatologists here want to take that one, but ketamine therapy is being asked. So
does anyone want to comment?
Dr.
So Dr.
That's a question for Dr. Antonelli.
Oh no. So ketamine is I think it's traditionally used as a horse sedative. It is used as and I believe in anesthesia. I'm not sure how common it's used for actual anesthesia, but it is used by pain centers now. I know that there are patients who have severe pain problems that can get they're called a pain infusion, but you're not getting infused with pain. You're getting infused with pain medicine, and ketamine is part of that cocktail, as we call it. It's not just ketamine. I believe it's ketamine, it's lidocaine, and there's a couple of various other medications. And those are classically used for patients with chronic pain syndromes like fibromyalgia. Not that I'm aware of used for lupus, but that would be more from pain management anesthesia.
Okay, great. Dr. Chacon, do you have any input on that? I know in your background with wound care or cystic fibrosis, you might have some experience. So.
I saw patients receiving the therapy, but it was for chronic pain, uncontrolled, well controlled with narcotics. And it is when we use these medications, like Dr. Antonelli said, maybe fibromyalgia, plus osteoarthritis, plus, this just chronic pain syndrome.
Kind of the more severe pain. Yeah.
Yeah, that is not common, and I didn't see patients with lupus receiving this therapy.
Okay. Okay, great. Thank you. I'm going to get back to a few more pre-submitted questions, and then I'll come back to the comment section. Let's see. So another endocrine question. Does having POTS change how lupus is treated and vice versa? Does it change the treatment, Dr. Siraj, of lupus?
No. So POTS is treated in lupus as any other. If the basic treatment for POTS is hydration, salt intake, compression stockings, do not change postures quickly, certain exercises that we teach them in the clinic, those kind of things that remain the standard of choice. Yes, if it is extreme, then we think about starting something called fludrocortisone or, some kind of corticosteroids, which is already incorporated in the treatment for lupus. But those treatments are at a stage where, we cannot, or the patient is having recurrent syncopal events or is at a risk of really harmful, or had an harmful event or something like that. But usually it's hydration, compression stockings, the general treatment for POTS. It's not any different in lupus patients versus it's not any different from the general population. So we like to do the basic lifestyle measures first.
Dr. Siraj, does graded exercise help POTS?
Yes, if they have been educated, that is something we tell them, certain postures, certain grading of exercises. That really helps the patient if they really dedicated to it. Those comes in the lifestyle measures.
Great. Thank you. I think I said endocrine there, though, so I apologize. But anyhow, we'll keep moving along. Dr. Antonelli, I was told to avoid mung bean and alfalfa sprouts because of lupus. Are there other foods or supplements that I should avoid?
So that one I had to look up. I have to confess, this is a patient teaching me. This is where we talk about as a physician, the more you know, the less you know. But this is good how patients can teach us. So apparently, sprouted mung beans and alfalfa sprouts have something called L-canavanine, which is an amino acid that can trigger lupus flares. So I learned that one there. The other things also are, I believe, echinacea, and I believe sulfas. So in general, sulfas, we tend to avoid things like Bactrim, which is a very common antibiotic. And then I would put a plug in there for cautious use of the supplement turmeric or curcumin, which is a very, very popular one right now. It has anti-inflammatory properties. It's used a lot in the eastern parts of the world, but it's often it is like all supplements. No supplements are regulated by the FDA, which means that the Food and Drug Administration, the FDA, doesn't go in and clarify what's in a supplement when a person is taking a supplement. So turmeric has been associated with liver problems. And so I would say if patients are wanting to take that for the anti-inflammatory properties, just to be cautious about it. I've had patients who wanted to start taking it, and so we kind of carefully monitored liver and kidneys while they were doing that.
Great.
Yeah.
Thank
And
you.
on that note, if you have something called congestive heart failure, from whatever consequences, we do have diuretics that we give, and our patients let us know, or the diagnosis of lupus in the chart helps us to avoid those diuretics in those subset of patients too.
Great. Thank you. Let's see. We have a question about menopause again. Is there evidence that women with lupus experience menopause earlier? And is there anything we should do to test for this possibility? Dr. Perella.
Yes, so a couple of things. So many factors can play into in having early menopause. I will say so. Two things. There's something called premature ovarian failure, which is also an autoimmune disease. So again, if you have predisposition to autoimmune disease, you can have other autoimmune conditions. If you stop having your periods before 40 years old or at 4 years old, it's a good idea to talk to your doctor about that. There's some tests. We can test for antibodies, and then we can also do hormonal testing to understand if your body, if the profile it's suggestive of menopause. So then that's that. And then the other, there are certain medications for lupus, and similar to even steroids. If you go through a lot of flares and you need to receive steroids consistently, and then unfortunately one of the side effects of the steroids is insulin resistance and weight gain. And then you have, again, metabolic syndrome that can also affect your ovarian reserve and can predispose you eventually over time into developing a early menopause. That will be around like 40 years old. Again, regardless if you're having irregular menstrual periods, if you are interested in having kids, it's a discussion that you have to have with your rheumatologist. There's tests that we can do, such as evaluating your ovarian reserve, and then depending on that, talk about should we freeze follicles, or should we freeze? Should we work on again fertility in general? So that's a good conversation to have early on with your rheumatologist as well. In the case that unfortunately you develop a menopause early, again, either 40, 45 years old, the other big conversation here is about hormonal replacement therapy. Keep in mind that when you develop early menopause, you're predisposed to other conditions such as cardiovascular disease, osteoporosis. So again, that's another conversation. Technically, hormonal replacement therapy is not contraindicated, but it's an important conversation to have. There are certain factors such as again having antiphospholipid syndrome, can increase the risk of having clots. Therefore, we cannot use hormonal replacement therapy for those patients. But again, early menopause is associated with increased cardiovascular disease and increased osteoporosis. So there's a lot of burden from those conditions. So again, just talking to your physician ahead of time to see if there's anything that we can do, not to bring the ovarian function back. Unfortunately, we cannot do that, but hormonal replacement therapy can be good enough to prevent, again, developing other chronic conditions over time.
Thank you.
If I could
You
put
actually go ahead.
If I could just put a plug in, there's one particular lupus medication that is associated with early menopause, which would be the cyclophosphamide or Cytoxan. It is not used very commonly, but we still use it today for very severe lupus, and that can cause early menopause. And so, if a woman has been exposed, there's usually a conversation about freezing follicles and prevention if pregnancy hasn't occurred, if there's more planned pregnancies.
Thank you very much. I know Dr. Perella kind of went into the next question, which was actually about hormone replacement therapy. But I will ask one question sort of as a continuation of that. I feel like we hear a lot from lupus patients, and in my own personal experience, no estrogen. They don't want us to have estrogen. Do you find that to be something that is correct and you feel strongly about?
So I will say again that that's a conversation that depends on like every patient. If there's high risk, so if the disease is active, so that will be an important factor here. If the disease is active, if the patient has antiphospholipid syndrome, then there is a high risk of flares in the disease or worsening the disease. So then that's a no hormonal replacement therapy. As I said before, estrogen does stimulate flares in general. So we want to avoid estrogen. And then the other concern is about the risk of clots, either DVT, or again, arterial clots. So then that's a conversation. In the case that, again, the disease is not active and then there are not other risk factors, again, in somebody who has like premature ovarian failure, somebody who goes into ovarian failure at 40 years old, then again will be a conversation between the endocrinologist and the rheumatologist. Hey, what is the risk here? Either we will increase the risk with again hormonal replacement therapy, or if we don't do anything about it, again, everything is about risk and benefits, right? We don't do anything about it, then in 10 years from now this patient will need to be taking medication for the rest of her life, or osteoporosis. So it's about a risk benefit. If I'm talking about somebody who is like 50 years old and then is having some mild symptoms about menopause, then I don't think it's reasonable to start hormonal replacement therapy. I think it's a case by case evaluation, again, discussion with the rheumatologist, how active the condition is. But overall, I will say that. So if you have an active lupus and you have severe disease with like frequent flares, then I will not recommend hormonal replacement therapy.
Great, thank you. I know I've also heard a lot too of, a lot of lupus patients have migraines. So I know that that's another factor that plays into the estrogen and hormone replacement therapy and all of that. So thank you for the information. Dr. Ballou, I think we're getting a question. I'm interpreting this. How does having lupus play into having procedures like dental work, colonoscopy, surgery? This person might need surgery on an ascending aortic aneurysm in the future, and other health monitoring that requires anesthesia. So it's really that anesthesia risk question.
Right. That is a good question. And it's an important question because eventually people come to a decision regarding whether procedures are necessary, even preventive procedures such as colonoscopies and such. As with all situations in lupus, it's best to consider having such procedures done when the lupus is not very active. So a meeting with the rheumatologist checking the laboratory tests, checking the examination to be certain that the lupus is under control, that the patient is on stable medications, then almost all procedures can be carried out successfully. But it requires that initial visit to be certain that everything is doing well and that the medications are appropriate. Sometimes medications may need to be stopped prior to procedure. This is unusual, but it can happen, and it's a question for your doctor. Usually, the medication is only stopped for a very short period of time and won't influence the lupus if it's under good control.
Do you find that patients have any trouble with recovery more so than, a different type of patient? Do they have problems kind of coming out of anesthesia or recovering from anesthesia or the side effects?
Not really. Actually, this is good news. I think that lupus patients, particularly if they stay on their current medications, recover quite well and probably not worse than any other person, even without lupus. So there's some good news there.
Absolutely. Yep, that is good news. I feel like we don't often have good news regarding our health, so it's always a positive thing to hear something like that. Okay, let's see. Dr. Chacon, I deal with SLE and DLE rashes. So that's discoid for our audience. It's been hard. Having it hard with some nerve problems in my feet, but suffer from fibroids. Also, what can I do to ease up on my pain? So let me see here. I think the question is, they're saying they have SLE and DLE and nerve issues in the feet and fibroids. Is there anything to help with the pain overall and the issues that they're having?
Yeah, good question. First, I would like to know the diagnosis more, like the patient has, for example, diabetes, maybe peripheral neuropathy, the patient has fibromyalgia, something that is affecting more the nerves in the legs. This is what I understand, no? Like if there is any vitamin deficiency, like a vitamin B12 level, no? Also, if there is any peripheral vascular disease that is affecting the lower extremities, and the patient has the combination of the pain and the nerves on the lower extremities, I'm thinking yes, having the combination of nerve, peripheral neuropathy, difficulty is important to make the correct diagnosis, no? But I will go for that, for making the correct diagnosis or the comorbidities, no, in order to be able to focus the management.
So more information is really needed there to see like really what's causing that nerve pain.
Yes, I will say that. No, what else? Because you're saying like it's a kind of nerve pain, but some patients they have just neuropathies,
Yeah.
no, which is common, for example, in people with diabetes, and sometimes just checking levels of B12, folate, it also might help.
Okay. Is the neuropathy common in lupus patients as well?
It could affect also, Dr. Antonelli, correct? Could
That's
affect
correct.
anything.
Yeah, absolutely.
Okay. Good to know. Thank you, Dr. Chacon. Okay, so let's see. We've got, my father had kidney disease and lost both kidneys and lived on dialysis for 8 years before he passed. I have lupus and fear kidney issues. I'm thinking about adding Benlysta to my treatment, but I need more information from other doctors. So I think this person wants some reassurance about taking Benlysta and addressing the fear of the kidney issues.
Yeah. So Benlysta is belimumab. This is an anti-BLyS agent that is approved for lupus, and most recently, in the last several years, it was added for the lupus nephritis or lupus kidney treatment. So the person could be reassured that Benlysta, if it's being recommended by the rheumatologist, that it's helpful. I would also say, especially with anxiety and regarding kidney function, that it's important to make sure that when the rheumatologist is ordering labs, that sometimes this happens where I'm ordering blood tests and urine tests, and the patient will go to the lab and they'll do the blood, and then they can't produce a urine specimen. And so, oh, no, don't worry, I'll get it next time. And they sort of forget about it. But a urine analysis is one of the most underutilized tests. We call it a liquid kidney biopsy, that we can often get a lot of information from that urine sample if there's active inflammation from the kidneys, from lupus or from diabetes and things like that. And so that's often something to not forget about. So, but yeah, I would say Benlysta is a good choice. And there is a new, I would put in a new plug that there is a new lupus medication that's coming out. I don't believe it's passed and been revealed yet. Maybe Dr. Blue could comment, but benletuzumab or something like that, that's going to be coming to market. So.
Yeah, I think we're hearing there's like, I don't know, 40 medications in the pipeline. Like it's something crazy. And we're all excited, of course, at the Lupus Foundation. I think when I started 13 years ago here, there was one, which was the release of Benlysta itself.
Yes.
So yeah, so exciting times in the rheumatology world. I'm sure all of you are delighted. So I would like to ask too, as far as the I guess the urine sample, how often should a lupus patient be giving a urine sample?
So in general, monitoring of lupus after an initial diagnosis in the immediate early period is usually very frequent. It's usually every quarter at the very least. If the lupus nephritis or kidney lupus is part of the initial diagnosis, it might be as frequent as every 2 to 3 weeks because you can really tell a response from things that work rapidly, like prednisone during induction therapy. As a person with lupus course progresses and the course is stabilized, we can sort of stretch things out. It might be as infrequent as every year, but I would say more commonly it would be every 6 months for the typical lupus patient.
Great, thank you. Okay, Dr. Siraj, should I be monitoring my blood pressure at home as a lupus patient?
Sure. Yes, the blood pressure is very important. There are two different entities in the blood pressure role in lupus patient. One is POTS, for example. If you have postural orthostatic hypotension, tachycardia kind of a picture, those patients need to monitor themselves, but those patients are very well aware of their changing in posture and their blood pressure going down and feeling dizzy, tired, brain fog, etc., etc. On the other hand, patients on treatment, such as corticosteroids or during the flare, or even if lupus nephritis on treatment, those can actually increase your blood pressure. So we usually recommend if there is certain changes like in vision or headaches or anything like that is triggering, that might not be just the lupus, but it could be the high blood pressure. So constant monitoring of their blood pressure is the goal. I think going to a primary care is very important for these patients to get that checked.
Okay, and that's included with people without kidney issues, or how about and without high blood pressure that we know of? Like, should a general lupus patient who is under control be checking their blood pressure regularly?
So they should be checking their blood pressure regularly. I mean, regularly means what? Once a week or twice a week versus every day. That changes with the kind of a patient that we're dealing with.
Okay, great. Thank you. Let's see here. I don't even know what this is. What do you think about taking methylene blue to treat lupus? Does anybody know what methylene blue is? You do?
Yeah.
Because I've never heard of it. Let's see. Go ahead, Dr. Chacon, if you've heard of it, take it away.
It is not approved to treat lupus. It is only FDA approved to treat a blood condition that is called methemoglobinemia. So please do not use this for lupus or any other autoimmune condition.
Okay. Does it have dangerous side effects that can possibly,
Yes.
hurt somebody with? Okay.
And it will not help the patient.
Okay. So don't take methylene blue, folks. Okay, and on that note, so we do have somebody who's been taking turmeric supplement and their liver levels were coming back elevated. Could it be the turmeric?
Yes.
Okay.
The question is whenever I have a patient who has newly elevated liver numbers, I always am asking about how much alcohol, how much Tylenol, how much anti-inflammatories. And when I get stuck, I go to my liver doctor friends who say, what supplements are they taking? And if they're taking the turmeric, stop the turmeric. So the idea would be stop the turmeric, check the levels again. If they come down, then you can more confidently say that could have been part of the problem.
Okay. Thank you. So watch that turmeric, folks. More information. Okay, so I'm just going through some comments here. We have thank you for the input. They know how to go about something that they asked, so that's very helpful. And we also had a comment that person gives urine every time they go for blood draws. They're in a lupus study and take IV Benlysta, so every month. So yes, good. Staying on top of your health. That's wonderful. So this person would like a little bit more information on Benlysta. I think a little bit more insight on Benlysta. They're maybe being considered for taking Benlysta, so they'd like more information on it.
So Benlysta is the first, as Adrian pointed out, it was the first biologic that was approved for lupus about 10 to 15 years ago. Before that, lupus was Plaquenil and prednisone and maybe some disease modifiers, which are the pills. So Benlysta is belimumab. So you can tell by the name, the last part of the name, the MAB is a monoclonal antibody. That means it has immunologic properties. So it works like your own immune system. It has an antibody that targets a specific part of the immune system and has been shown to lower lupus disease activity. Particularly, it helps with things like musculoskeletal symptoms like joint pains, arthralgias, skin symptoms like rashes, and lupus nephritis. It can be given both injection, so as a home injectable in something that looks like a pen. The medicine is in there, and there's usually it's an auto injector. I don't know if it comes in a syringe where the needle is in there and you put it, I can't remember if it's your lungs or your tummy, put it under the skin, I believe every week. If a person is not interested in doing the home injectable, it can be given once a month as an IV. So you go into the clinic or the hospital, and then the nurse puts in the IV, gives you an equivalent dose through the IV. It takes several months to work, at the minimum 2 to 3 months, but as long as 6 months in some patients. So, and because it's very targeted, I would say it potentially has higher infection risk for patients taking it compared to those not taking it. And so that's one thing we're always monitoring, looking for chronic infections. And there's also, I believe it's a black box warning about can cause worse depression in patients who are taking Benlysta. So that's something to be mindful of, that if a person is already has depression and is considering it to be in the conversation with your rheumatologist about whether or not if you're going to start Benlysta, to be watching your mood if it goes down.
Okay, thank you. We're also being asked side effects for Saphnelo.
So Saphnelo is also a targeted, I believe, anti-interferon. Again, will be lowered immune system. I believe because it has anti-interferon type properties, the infection profile is a little bit different than Benlysta, but similar, where you're lowering the immune system in a targeted way.
Is it a stronger immune suppression than you would find with Benlysta?
I would not use that terminology to say that it's stronger or not. To be frank, it's newer, and so I have generally less experience using it. I think I've only used it once, and so just general discomfort because it's newer. But I believe because it also doesn't have that labeling where we're not using it with lupus nephritis and things like that. So it's a little bit more for general lupus, but I wouldn't consider it stronger or weaker or anything like that. It's a biologic. They're strong medications.
Okay. Great. Thank you. Getting a question. Let's see. I guess this could kind of be a crossover rheumatology and a little bit of endocrine as well. Is it better to take a multivitamin for women over 50 years old versus 6 different vitamins? So is a multivitamin better than taking like, a separate vitamin B, a separate vitamin D, whatever?
I don't know well, maybe I'll start making some comments. So I think like number one, the most important thing is make sure that you have a healthy diet. A diet that includes like a lot of vegetables, fruits. A balanced diet is very, very important. I think that's more important than having supplements in general. Having said, again, going back to what Dr. Antonelli was mentioning before, we have to watch out because most of these supplements they don't have like any control, so sometimes we don't know what it's in them. Again, because of that, there's not that many trials that prove is multivitamins versus the other are more effective or benefits in general. What we do know, again, particularly for women, vitamin D is very, very important for bone health. Okay, therefore, again, particularly if you are perimenopausal or menopausal, making sure that you have enough vitamin D is very important. For us here in Ohio, because again we don't have that much sun exposure, it's a little bit more important to make sure that we have vitamin D. But it doesn't matter if you take the vitamin D in a multivitamin compared to a vitamin D alone. I typically prefer the vitamin D alone compared to the multivitamins. And then some other things that are important for endocrinology, if you're taking metformin, which is a medication that is very commonly used for diabetes in general, type 2 diabetes, that can cause vitamin B12 deficiency. So we advise also our patients to make sure that they have vitamin B12. In terms of calcium, again, we prefer patients to have enough calcium supplement from diet rather than oral supplement. Somebody who, and even being again either lactose intolerant or not doing dairy products from animals, still there's many ways where you can have good calcium supplement from your diet. If somebody who tells me like absolutely they don't have 5 portions per day, then we start talking about calcium supplements with your primary care physician, your endocrinologist, or your rheumatologist. But that's kind of like where our standpoint from endocrine point of view about multivitamins. I'm not sure rheumatology if there's something else that
I would agree, not anything specific from rheumatology, but my advice to patients is generally that a multivitamin is very important if a patient has what I call a Swiss cheese diet. Not that you're eating Swiss cheese, but that your diet looks like a piece of Swiss cheese. It has a big hole. I'm not going to eat X or Y or Z, for example. And so, for example, Adrian, there was a question about a person who had a lot of food allergies, for example. So if you're going to avoid a certain large part of a healthy, balanced diet, like Dr. Perella said, then I think a multivitamin is very important. But aside from that, if you're really eating a very balanced diet, I don't feel very strongly that a multivitamin is very important. What Dr. Perella did say about the calcium and vitamin D, I think is very imperative. And I don't think we need to wait until we're at menopause. I would say throughout the entire lifespan, we should be thinking about calcium intake. That, yes, we worry about our little children getting enough. They're not growing taller. Okay, now you're 20 years old, you grew tall enough, that's it. Really, we should be thinking about it from the age of 20 to the grave. If anybody wants to, the National Osteoporosis Foundation, the NOF, has a lovely calcium calculator. If you just type into the Google NOF calcium diet calculator, it comes up a very nice weekly average where you can plug in what you're eating and if you're taking supplements and things like that. So it really can kind of look at a person's diet to see, are you taking it? And whether or not adding a supplement like Tums, which is just simple elemental calcium, could be good, a good addition.
It's a great suggestion. I haven't heard of that before. And I will do that, Dr. Antonelli.
Good. Perfect.
Yeah.
Perfect.
Okay, so Dr. Siraj, what are the most common heart problems that lupus patients have? I think you touched a little bit on that, but we'll go over it one more time.
It's a spectrum, and it's a lecture in itself, actually. I'm glad that this question is brought, but let me explain you. There's nothing one common than the other one when it comes to lupus or any other autoimmune diseases. So it's a wide spectrum of diseases that can manifest itself at certain age groups. So it goes by whether it's the autoimmune part or your immune system working against your body or against your heart. For example, if it's getting the sac around your heart getting inflamed because of it, so it's pericarditis. If it is something to do with the muscle of the heart, it's myocarditis. If it's the valve problems, then you will have what we call infective endocarditis, but it's a non-infective form of an endocarditis, means that the valves are getting infected. So those are the few things that just end in an era of immune system going, or you're having a flare or something like that. On the other hand, if you have pro-inflammatory state, for example, the inflammation is higher, you can have atherosclerosis. You can have DVTs also if it is accompanied by something called antiphospholipid antibody, if you have that condition manifesting itself. Or it could be related to the treatment. There are certain treatments of lupus, such as Plaquenil. If the patients are taking with some of their antidepressants, for example, that can cause QT prolongation and some kind of electrical problems, including, life-threatening ventricular tachycardias and ventricular arrhythmias. So it's a mix of everything, so nothing one is more common than the other one. It's just like the time that, if you're having a flare, this is more common versus, if it's something that is chronic, indolent over a course of years, you're developing arterial diseases and stuff like that, or later in life as a consequences of those treatment modalities that we're giving to the patients. So it's a whole spectrum that we deal with in patients. Even if patients have coronary artery disease, it's a wider perspective. They just have atherosclerosis or there's plaque buildup. Or if it is just because of the thrombosis, they are more prone of having these clots in their legs or clots in the arteries. They're more prone of having heart attacks at a younger age that we've seen. The treatment of choice remains the same. They need to be on a blood thinning medication. So nothing is one commoner than the other one, but it's just a manifestation how it is multifactorial when it's coming to the heart. And on top, we've been discussing about POTS. So POTS is one of the most talked about when it comes to autoimmune diseases.
Great. Thank you, Dr. Siraj. Let's see. I'm going to go back a little bit here. When Plaquenil is off the table for use because of eye damage and risk of vision loss, what are the go-to medications typically used by doctors? Dr. Antonelli, you want to take that?
Yeah, sure. So I think, Plaquenil is our go-to because of, as I mentioned, improved morbidity and mortality in lupus patients who take it. But if Plaquenil is off the table, and that's a very specific situation where we say if you have retinal issues, if you have eye issues where the eye doctor says it's just not safe, we understand that and we say, okay, that's off the table. Then it becomes that lupus is more of a disease manifestation target. So there's no other alternative medication where we would say, yep, all lupus patients should be on X, Y, Z. I don't have another backup drug. If, for example, a lupus patient has a lot of joint manifestations, a lot of arthralgias, arthritis, we would go to something like methotrexate, which is our general go-to. We could go to something like Benlysta. If, on the other hand, if it was more just discoid lupus, that could be treated just with topicals and not necessarily using a systemic unless it's quite intense. If it's something like lupus nephritis, we have a regimented protocol using either mycophenolate, Cellcept, or Cytoxin, or Benlysta. But it becomes more of the which organ is involved, and then the algorithm progresses, right?
Okay, gotcha. So there's options. I mean, that's the good news.
Absolutely,
right?
Absolutely.
Yeah. Okay, let's see. Okay, she provided that. Okay, I'm going to go back here. What are let's see. Sorry about that. What are the chances of my children inheriting lupus? Dr. Ballou, you want to take that one?
Yeah. There's a small risk. So the chance of any single woman in the United States, any woman in the United States getting lupus is about 1 per 1,000 women.
Mhm.
If you have a direct relative, that means sister, parent, child with lupus, your chances increased perhaps 2 or 3 times, and it could be as much as 3 per 1,000 or perhaps a little bit more. Still not a high risk, but a slight increased risk. If you have a family member with lupus, it's good to be aware of this and to avoid any things that could provoke lupus, like excessive sun exposure, cigarette smoking, weight gain, etc.
What about other autoimmune diseases in the family? Does that put a person's child at risk? So, like, let's say the mother has lupus and the uncle has, I don't know, psoriatic arthritis, and there's just autoimmune in the family. One has rheumatoid arthritis, something. Is there an increased risk there for the children?
All of the autoimmune diseases share a slight increased risk. Certainly, our endocrinologist can tell you that people with thyroid disease have autoimmune disease, and they're a slight increased risk of things like Sjogren's or lupus. The same would be true for inflammatory bowel disease and other autoimmune diseases. Slight increased risk.
Okay. So moms and dads, it's good to have that discussion with the pediatrician to make sure that they know there's family history of autoimmune conditions. So
Exactly.
yeah. Okay, great. Thanks, Dr. Ballou. And speaking of comorbidities, what is it that you as physicians do to monitor comorbidities? I mean, we know you're looking at lupus, but what about things like Sjogren's and other autoimmune diseases?
I would say that every time a patient comes in, we do something called the review of systems. And so even though we might be focusing in on what the patient comes in for, be it lupus or whatever, we're still always trained to try to keep an open mind. Is there something else going on? And from my point of view as a rheumatologist, I think it's my job to make sure that we're not missing is something else coming up, right? I wouldn't want to miss if lupus is evolving into something like lupus plus Sjogren's or lupus plus osteoporosis, right? That's my job as the rheumatologist. But I know that primary care physicians are quite overworked. And so my job is also to help do the best I can to take care of my patients. And so if they have a concern and they're waiting to see their primary care, to help screen for things through that review of systems.
Great. Thank you. Let's see. When I was diagnosed with fibromyalgia years ago, it was unknown and not taken seriously. Do doctors believe in their patients with fibromyalgia now, of course, diagnosed with lupus afterwards? So they want to know about the legitimacy, really, of fibromyalgia now in the medical community.
Yeah, I think that's a tough one, and that patient unfortunately is not alone. That's a very common situation that I've had a lot of patients who say that my doctor told me that fibromyalgia is in my head, that this is not a real disease. And that's definitely not true. That fibromyalgia is a real disease, that it's unfortunate that there are still now hopefully a much smaller health professional population who are still have that sort of biased opinion. But fibromyalgia is what we call a central pain processing disorder. There's a higher percentage of autoimmune patients who suffer from fibromyalgia. So as a rheumatologist, it's our job to know about these conditions. Beck, what was the original question? Yes, the validity. Yes, it is a real disease. And so I always like to tell my patients who have kind of like wondered, why don't people feel like it's real? I would say that there's an under-education of health professionals about fibromyalgia, that even though it's one of the conditions that we might have seen described 200, 300 years ago as fibromyositis and has many different types of names and things like that, that we still do really a poor job of educating our medical students and nurse practitioner students and things like that about what is out there. But the truth is that it's real. If we look at functional MRI scans, which is not something we do in clinical practice, but if we do an MRI of a brain and use tagged sugar, and we say, okay, where is the most amount of sugar going into the brain in a fibromyalgia patient, that the pain centers in the brain are very, very highly active compared to patients who don't have that central pain component. And so we know it's real. It's unfortunate that we don't have an easy test, and so people can be brushed off, but it is real, and I'm sorry that patient had that experience.
Yeah. Well, it's good to know that I guess they've come a ways, maybe not a long ways, but a ways to understanding it a little bit more and knowing that it's a real condition and that the patients are suffering. So
that's right.
That's let's hope it's like a lupus thing in 10 years. We got a lot of medications and a lot of stuff coming down, hopefully.
Exactly.
So, okay. When you get labs to show inflammation and active lupus, does this reflect the previous 6 months or this point in time? Great question.
That is a great question. It definitely, I would say it's very much in the moment. I know Dr. Ballou probably can't hear me, so maybe he could comment also. But I'm thinking of a lupus nephritis patient where, we're checking labs in the hospital on a daily or a bi-daily basis. And so, even as the patient is discharged, we say, okay, I'm going to get weekly labs, weekly urine, biweekly, and then so on. And we stretch things out. But yes, when a patient is coming only every 3 months or every 6 months to get labs, the labs are pretty much looking at that moment in time. The only one where I would say maybe it is looking at the previous several weeks would be like the erythrocyte sedimentation rate, or the ESR, which can look back several weeks and reflect how much inflammation's been going on.
Okay, great. Dr. Ballou, I know you're having trouble hearing Dr. Antonelli. Do you have anything you want to say about getting your labs drawn? Is it the previous 6 months or is it this current point in time? Do you have anything you wanted to add there?
Yeah, I unfortunately didn't hear Dr. Antonelli's response, but I would say the answer is both. We have tests that reflect immediate symptoms, and we have tests that reflect how the person's been doing over the past 3 or even 6 months. So it's a combination of tests. That's why you go to the lab, you get a urine test and several tubes of blood to test for both the immediate symptoms and symptoms that have been going on for a while.
Yeah, I suppose it matters too on what labs are being drawn, right? So
Correct.
with each patient. So some might
That's right.
you might see that are more immediate, and some that you're drawing maybe there's more intense blood work going on or a lot more tests, and you might be looking for things in the past. So I guess it's a both answer to the question, right?
Correct.
Right. Okay, thank you. So let's see. I'm gonna get, one person is saying they get gut cramps and nausea a lot. So I am gonna ask a question about GI effects of lupus. So that'll be rheumatology. So any one of you can take it, but we'll throw it to Dr. Antonelli since Dr. Ballou just chimed in.
So it was specifically about like belly cramping and things like that.
Yeah, and nausea, it says, yeah.
Yeah. So, I mean, the first thing that comes to mind is the GI system is maybe the least famous for being affected by lupus. That lupoid hepatitis, where the liver is involved, is one of those terrible, severe, rarely heard of things, but it can happen. And lupus colitis can happen. But I would say the more common thing is medication side effects that can cause gut issues. So things like nausea related to Plaquenil, belly issues related to taking prednisone or taking anti-inflammatories for lupus. That would be more common than seeing specifically lupus related gut issues.
Okay. All right. Thank you. Let's see. We have my family doc takes an annual urine sample, but my rheumatologist never does. Should I be concerned? I know the blood work regularly includes a test for creatinine.
So I'll comment. No, oh, is he going to comment?
You want to answer, Dr. Ballou?
There you go.
Of course. A urine test is extremely important in patients with lupus. And it should be done at least every 6 months in all patients with lupus. If a patient with lupus has any abnormalities of the urine test, it should be done every 3 months. It's, of course, a very simple test, but it's a very important test. We should all be aware, including all lupus patients, that involvement of the kidneys is the most serious problem that can occur in lupus. So getting your urine checked every 3 months or every 6 months, or at least annually, at the very least, is appropriate for everyone.
What do you recommend as far as like a patient who knows they should be getting, more urine samples, but isn't? Like, how do you gently suggest that happens to a physician? It's kind of an odd position to be in.
If the physician is reluctant for some reason, and I can't imagine what reason that would be, to obtain a urine test, simply the patient can contact the rheumatologist even by telephone and say it's been, a year since I've had a urine test. The rheumatologist can then go ahead and order it.
Okay. So just maybe a gentle reminder.
Yes.
I think these platforms are increasing awareness. So, for example, if a patient has not seen a rheumatologist and coming to me for a cardiac issue, well, my responsibility is to refer them back. Sometimes they fall off the system, or their flare has been under control. So, not taking anything, and then I'm not aware. It's just raising because I won't do a urine test for a lupus patient in my office. So it's like these platforms, like right now we are having a discussion, opens up that venue, that awareness, education. What's new coming in treatment helps to increase awareness.
Right, exactly. Okay, great. I think we're getting close here. We should have Dr. Singer joining us soon. So I want to just make sure we ask 2 more questions. Stress makes my lupus worse. How do I manage my stress levels without killing my adrenals and making my lupus flare?
Nobody wants to kill their adrenals.
Right.
Dr. Perella, we're going to leave you that one.
All right. So, well, I think that the only way how lupus can kill your adrenal, technically, if it's there's something, if there's like now I'm blanking, sorry, the infarct of the adrenal gland, because autophospholipid syndrome, that will be one of the higher risk factors to have that condition, where again there's an infarct, the blood flow to the both adrenals, because in order to again lose cortisol production, you have to lose both of your adrenals. If you only lose one of your adrenals for any reason, the other adrenal gland it's able to compensate. So that's one thing that is important. It's very unlikely that you're going to lose both of your adrenals. Now, when you use steroids for a very long time, high dose steroids, typically for anybody more than like 70 pounds, we are talking about if you're using more than 5 milligrams of prednisone, that will be just kind of like putting it in a very broad spectrum. If you use it for a very long time, more than a couple of weeks, or if you are using higher dose steroids for like a shorter period of time, most likely what your doctor is going to do is going to suggest a slow taper. It's going to tell you to bring down the dose of your prednisone slowly, because when we use high dose steroids, what we are telling the adrenal gland is that I am taking the cortisol so you don't have to produce, because again, the body doesn't want to have too much cortisol in the system. It's not, again, the body is about balance. We don't want too much or too little of anything. We want to have enough hormones. So again, when we take steroids, then our glands go to sleep, and when they are being sleeping for a long time, we want to make sure that we're giving them the chance to wake up. And the way that happens is by, again, tapering down the steroids slowly. Now, again, when you take the steroids for, again, a very long period of time, now we're talking about months, maybe years, then it's very unlikely that your adrenal glands are going to wake up and they're going to produce cortisol on their own. In that scenario, again, most likely, some rheumatologists feel comfortable about checking if your adrenal glands are waking up. And in some other cases, they will refer them to endocrinologists to be 100% sure that your adrenal it's picking up. But I will say that, like, in any case, and then this will be maybe more for the rheumatologists in the panel, but I think like everybody will always try to give you the least amount of steroid possible that you need. If you need a steroid, then that's different, you need it, but we would like to have like a slow taper to, again, give a chance of the adrenals to wake up. And now so that's the question about the adrenal and not killing the adrenals. Another thing that is very important to clarify is that stress. We all go through stress. Stress is not, well, and I understand, like, we all go through different reasons for stress. I'm not saying everybody's issues is, but what I'm trying to say is that our adrenal, our cortisol, it's the hormone that helps our body deal with that stress, either that is a personal issue or a disease, right? So it's stress itself. It's the cortisol that the adrenal is producing, so your body can deal with the stressful event. It's not going to destroy the adrenal, because that's physiologic, okay? Now, what are the things that can bring down the stress? Again, make sure that you have a balanced diet when possible. Make sure that you have enough green vegetables. Try to avoid processed food as much as possible. Fast food, remember that they have a lot of preservative, and that, again, can trigger your immune system as well. Exercise, physical activity, it's very important when possible. Sleeping well, it's an important a factor. When you are not sleeping, again, your body is under stress. So then, if you a big a recommendation for my patients in general, if you are snoring at night, if you are waking up multiple times, gasping for air, maybe talking to your primary care physician about doing a sleep study, because obstructive sleep apnea is a condition that silently contributes to stress and can also affect immune disease in general. Yeah.
Great, thank you. And I think that's pretty important too, like as far as like the heart is concerned, Dr. Siraj, is that the sleep obviously can impact more than we realize. So not getting good quality sleep is huge, especially for as lupus patients. I think that's important. Okay, we're going to try to fit in maybe one or two more questions here. We're still waiting for Dr. Singer, so hopefully she chimes in soon.
Can we do the question about the vaccines?
Yep, that's one of the ones that I have circled right here.
Good.
Okay. So we do have a question about vaccines. So are there any lupus medications that I should stop taking before taking vaccines? If yes, how long should I stop taking the medication?
So that was an important one, because I think it's the time of year when we say, please get your flu shot. Please, please, please. My arm is still sore from a couple days ago. So, so the two medications that are important, there's some ACR guidelines, the American College of Rheumatology guidelines. And the only two medications that we need to think about when giving a vaccine is methotrexate and rituximab or Rituxan. And so if a person is taking methotrexate for lupus, they actually just need to hold one dose after the flu shot. And it's just the flu shot specifically. And that's only if the patient and physician think that the risks of a flare afterwards are potentially worth it. If a person has some active lupus disease and skipping one dose of methotrexate is too risky, that we would just skip that and don't worry about it, just continue it. And the other one being the rituximab, and this is very important because rituximab influences how a body produces antibody. So the actual process that the vaccine stimulates the immune system education, as the timing of the vaccine, that persons taking Rituxan, it would be ideal to get those vaccines when the Rituxan is very low in the system. So 4 or 5, potentially even 6 months after the last dose of Rituxan, to allow for good immune system education. If that's not possible, if a person is getting more frequent Rituxan, it's better to get the vaccine anyway, and that those are the only 2 medications. These are both assuming that these are not live vaccines. There's very rare live vaccines that are given in the United States. The 2 that I'm thinking of, and Dr. Chacon can help me, are rabies and I believe the yellow fever vaccine. Anything else, Dr. Chacon?
No, I was thinking also about COVID vaccine, also with methotrexate, which is not live. I think it's also 1 week.
Correct.
No? And also the pneumonia vaccine, also it's not live vaccine, but it's also 1 week for the methotrexate. And for Plaquenil, no need of stop anything.
Correct.
Yeah, that actually brings up a really good thought on vaccines, because recently they've changed the guidelines for RSV. So how does the new guidelines for RSV impact lupus patients? Anyone?
I will just speak as somebody who's never written for the RSV vaccine, but tells all of my 60+ patients, it's a new vaccine. Please consider getting it. It's only a once in a lifetime vaccine. It is not a live vaccine, but it is I believe it's an mRNA vaccine. So it's a giving the immune system the book and says, here, you read this. It's not actually even giving you the protein. So.
Okay, great. Good to know. Okay, so we have one last audience question. I am ANA positive and anti-dsDNA positive, and oh boy, I don't know what this is. Crithidia lucile positive, but no other positive labs and no major symptoms yet. So my doctor said she can't officially say I have lupus, but she started me on Plaquenil. Hear this a lot. Does this mean I pretty much have lupus, or will I have it soon? I'm not sure I understand the borderline diagnosis.
Dr. Ballou, we're going to leave that one for Dr.
Ballou. That one's for you.
Well, the answer is maybe.
Yeah, it's true.
To have a positive test for anti-DNA is of some concern. Of course, it doesn't mean that you're definitely going to have lupus, but it suggests that you need to be followed closely and be careful regarding any symptoms you may have. I would avoid extensive sun exposure. Certainly, you don't want to be a smoker. Certainly, you want to take care of yourself, have a proper diet, appropriate exercise, maintain a good weight, and do all the things that we would normally recommend for overall health in a person, knowing that there is a risk at some point down the road. I would suggest an annual, at least, follow-up with the rheumatologist.
Great. And I will say that is something here at the Lupus Foundation, a Greater Ohio chapter, that we hear quite a bit. Patients who have something called undifferentiated connective tissue disease. So the rheumatologist believes you may have something going on, and so they diagnose you with that, or say it's just general, we need to watch you. But I think Dr. Ballou, obviously his wise experience tells us that you need to be monitored, and that's the most important thing, to be watched and followed over time to ensure that you're in good hands and healthy as can be. So
certainly I would.
Yeah, I would too. I did for many years. I was undifferentiated for many years before I got my lupus diagnosis. So very, very common thing. And I always looked at it, it was, better to you could call it whatever you want. It was better to just make sure that the symptoms were being controlled and that my inflammation was being controlled. So I think that's the most important thing. But I understand from a patient perspective why that's hard to really grasp. But I think we're going to go ahead. I think Dr. Singer must have had some type of complication. So I did speak briefly with Alex through text, who mentioned what we will do is give Dr. Singer an opportunity to record something for us that we can put either on some type of web-based programming at a later date so that you all have that information. So there you go. All social channels at Lupus Greater Ohio, or OH, I should say. So, all right. Thank you so much to all of our doctors. Your excellent responses and our interactive discussion is always wonderful. And this concludes our Ask the Doc Town Hall. Thank you again to our sponsors, the Ohio Commission on Minority Health and GSK, and another shout out to our incredible panel of experts. And I just want to remind everybody, don't forget to check your email for the evaluation. If you complete it, you'll be entered into a drawing for your chance to win one of two $50 gift cards to Target. Thank you again. And please visit lupusgreaterohio.org for information on future programming. All right. Thanks, everyone. We're getting a lot of thank yous. Thank you, doctors.
you.
Enjoy your Saturday.
Thank you.
Bye.
Thank you.
Take care.
Bye-bye.